Thank you, Prabhuda. Good afternoon, dear sir, madam, and all my colleagues. I'm Dr. Channa. I'm a Registrar in Nutrition. Uh, and first of all, I would like to thank madam for giving us this opportunity. Now onwards, I'm going to discuss about the role of medical nutrition therapy in COPD. Actually, this is one of very common questions that is being asked from us, from all the patients, regardless their disease condition, regardless whether we are a junior doctor or a very senior consultant. Almost all the patients would like to know answer for this question. By going through this presentation, we'll try to find an answer for this question in regard to the COPD. Okay, in my presentation, first I will briefly discuss why the nutrition is important in COPD, then the pathophysiology of nutritional deprivation in COPD, and few words on how to identify and diagnose malnutrition in COPD patients, and finally how to optimize their nutritional status. Okay, as Madam mentioned, COPD is a progressive lung disease. It is caused by, which is associated with actually chronic inflammation, and this lung disease is associated with long-term drugs, and it has many exacerbations and associated with recurrent hospital admissions. So it is considered that one of the most costly conditions. According to the British Lung Foundation, in 2017, there were 3 million people in UK who was diagnosed with COPD, and they had to bear a direct cost of 1.8 billion sterling pounds in treating these COPD patients. When it comes to the total overall cost, it was around 48.5 billion sterling pounds. It was a massive amount. Unfortunately, I don't have the figures in relation to the Sri Lanka, but here also our health system also has to spend a lot of money on managing COPD. And malnutrition in COPD can increase the health costs more. Why? Because it is associated with significantly higher emergency hospitalization rates and increased length of hospital stay. Some reports say that healthcare costs of managing individuals with malnutrition are 3 to 4 times greater than that of managing non-malnourished COPD patients. Because this malnutrition in COPD can clearly reduce the muscle strength of the patient, which can eventually reduce the respiratory muscle function, and it can increase the hospital admissions, it can lengthen the hospital stays, finally increasing the mortality and increasing the healthcare costs. How prevalent this malnutrition in COPD? Actually, I couldn't find any data on global prevalence of malnutrition in COPD patients, but some studies have mentioned that there are around 1 in 3 inpatients and 1 in 5 outpatients were, with COPD were having malnutrition. That means every 30% of inward patients with acute exacerbations are malnourished, and 20% of clinic patients with COPD are malnourished. Actually, this malnutrition can develop gradually over several years, so it might suddenly develop after an acute exacerbation, and this is multifactorial. This could be either due to poor intake leading to poor undernutrition or nutritional deprivation, and there is a component of sarcopenia as well. Sarcopenia is the loss of skeletal muscle mass and strength, and there is a part of cachexia. Cachexia is the loss of fat-free mass due to inflammatory cytokines. Because being a inflammatory disease, COPD can lead to cachexia as well, which we know as pulmonary cachexia. And there is a component of frailty as well. This is the schematic diagram of what I have described. So poor nutrition, sarcopenia, pulmonary cachexia, frailty, everything get together and cause malnutrition in these patients. So we'll go through these one by one quickly. When it comes to the nutritional deprivation, it is actually it occurs due to a mismatch between energy intake and energy requirement. Usually these patients are having high energy course. They need more energy than other people, and their intake is significantly reduced, and they are having a chronic inflammation and a hypoxic stage, and most of these patients are elderly people, and action of aging is also on them, and the medication also can lead them to nutritional problems, especially steroids, and the social, environmental, and psychological factors also can lead them into malnutrition. Why their energy requirement is increased? It is mainly due to three reasons. First thing, they have to put an additional effort on breathing. The respiratory effort is high. To compensate this respiratory effort or to support this respiratory effort, they need more energy. And the chronic inflammation itself needs some energy. And if the copulmonale is there, the cardiac effort also would be increased. So it also needs some additional energy. So they end up getting a higher resting energy expenditure, which is nearly 10 to 15% higher than the normal individual. And though they have this higher energy requirement, their food intake is considerably affected due to several reasons. One is the cytokine-induced anorexia. Other than that, these people get fatigued very easily and get dyspneic while eating, so they end up at the middle of their meal, and then there could be some associated esophageal reflux and dyspeptic symptoms which lead to reduced intake. And some people tend to breathe through their mouth for a long time. It can dry out their oral mucosa and alter the taste sensation. And if the copulmonale is there, they can get gut edema, which can reduce the absorptive capacity. And polypharmacy, physical inactivity, also can reduce the appetite. And this can be associated with several psychological factors as well. Some of these patients may end up getting depressed because of their limitations in day-to-day activities, and apathy and lack of motivation also can lead to reduced food intake. And the social support is also very important. Lack of social support also, especially in preparing food and serving food, also lead to problems in intake. And they are having an exaggerated muscle wasting, maybe due to a poor nutrition, the reduced amount of proteins, calcium, magnesium, potassium, phosphorus, and especially vitamin D, because most of these people tend to stay inside the houses. They get a very little amount of sun exposure, so most of them are vitamin D deficient. That also can exaggerate the muscle wasting and reduce physical activity. And chronic hypoxia also increase the muscle catabolism due to the oxidative stress. And the aging can be accelerated because of all these reasons. And the chronic inflammation is also playing a huge role, because inflammatory cytokines can act on hypothalamus, the arcuate nucleus of hypothalamus, and reduce the appetite. And the cytokines directly act on muscles and increase the muscle catabolism, and it can augment an insulin resistance as well, so muscles will not be able to get enough fuel for their action. So at the end, muscles tend to get catabolized rapidly. I'll skip these slides. And as I mentioned, chronic hypoxia also plays a huge role in increasing muscle catabolism by forming free radicals and inducing proteolysis. And there are sort of a muscle adaptation that is taking place in COPD patients. The type 1 muscle fibers get replaced by type 2B muscle fibers. These type 1 muscle fibers have more mitochondria, more oxidative enzymes, and capable of endurance activities. The type 2B fibers have less oxidative enzymes and less mitochondria, and they are good in anaerobic activities. So the amount of these endurance or oxidative muscle fibers go down, and the patient gets fatigued very easily, and muscle fibrosis and reduction in glycogen stores also act deleteriously on these patients. So at the end, the patients develop poor respiratory effort, poor exercise tolerance, and poor disease outcome. And steroids, most of these patients are on steroids, and as we all know, steroids can induce myopathy by inhibiting muscle protein synthesis. It can increase the muscle catabolism as well. Other than that, they can induce osteopenia and osteoporosis, and can cause dyspeptic symptoms and insulin resistance. All of these can act adversely and cause malnutrition on these patients. And there is this thing called board index. Actually, board index is a simple index which we use to calculate the 4-year survival of the patients with COPD. To calculate this, we consider the BMI of the patient and FEV1 value of the patient and MMRC dyspnea score and their exercise capacity. Exercise capacity is measured by the 6-minute walking distance. Then we give a score for each of these parameters and finally calculate the index or board index score. If the board index is high, that means the estimated 4-year survival is less. If the BMI is low, that means the patient gets more marks and the estimated 4-year survival goes down. So having a proper BMI is very important to maintain or to have a good disease outcome. Then it is very important to identify the malnutrition or the malnourished COPD patients. Actually, we need to take a proper history and examine the patient to identify whether there are any risk factors on malnutrition. If the patient is having an unintentional weight loss during last 3 to 6 months, or whether the patient is having a significant loss of appetite or reduced intake or dyspeptic symptoms, then we should be alert. And it is always better to check the BMI, check the hand grip strength. Actually, hand grip strength provides us a lot of information. We can ask the patient to squeeze 2 of our fingers with the maximum force they can elicit, and subjectively we can see whether the patient is able to provide a proper grip. With that, we can subjectively assess the patient's hand grip strength. But there is another gadget called handheld dynamometer, which we can use to quantify the hand grip strength. Unfortunately, we don't have that gadget in our hospital. And we can see whether there are any evidence of subcutaneous fat loss or muscle wasting. If those features are there, then it is always better to arrange a proper medical nutrition therapy to take this patient out from the malnourished stage. Actually, the NICE guidelines on COPD, especially the NICE guideline in 2018, suggest to use a screening tool, a nutrition screening tool, in almost all the stable COPD patients to identify those who are at risk of malnutrition. The suggested tool is the MUST tool. MUST tool means Malnutrition Universal Screening Tool. It is a very simple tool which is being validated to be used on elderly population as well as in community. So we can use this in our clinic patients. Here, only a little thing to do. We can check the BMI and give a score, and we can ask the patient whether there are any documented weight loss, and we can give a score accordingly, and we can consider the acute disease effect. According to that, the total score is calculated, and those who are having a low, and then according to the total score, we can categorize them into 3 groups: low risk, medium risk, and high risk. If the patient is at low risk, that means he's not having any risk of being malnourished, so we can review him in 6 months time or in 1 year time. But if the patient is having a medium risk or high risk, then we have to properly evaluate the patient and arrange the relevant medical nutrition therapy. In case if we are unable to measure the BMI, especially if the clinic is very heavy, then we can simply measure the mid-upper arm circumference. If the mid-upper arm circumference is below 23 centimeters, then it often indicates the BMI of less than 20. And we can use this in edematous patients as well, especially those who are having copulmonale. And we can assess the hand grip strength as well. I will skip this slide. And then once we identify those malnourished people, we have to provide them with proper nutritional counseling and proper nutrition management plan. So we have to postulate some goals. The main goal is to improve the nutritional status. Then we can increase the lean body mass and stabilize the weight and retain function. At the same time, we can improve the respiratory functions as well. Actually, these goals should be very subjective. It should be postulated according to the patient's clinical status. And if the patient is on having stable COPD, then we can target for 2 kilo or more weight gain. But if the patient is on acute exacerbation, then our main concern is to minimize the muscle loss and weight loss and to improve his or her immunity. And there are several guidelines which stress the importance of managing malnutrition in COPD. This is the British guideline, and this is the European guideline, and this is the American guideline published by the American Lung Association. According to all these guidelines, the energy provision is very important. For a non-malnourished patient, around 30-35 kcal per kg per day energy would be enough. But for a malnourished parent, we have to increase it up to 45 kcal per kg per day. And the protein requirement is very important. Usually, a normal adult would need around 0.8 grams of protein per kg per day. But for these malnourished COPD patients, they would end up needing around 1.5 grams of protein per kg per day. If the patient is obese, then we can use the ideal body weight to calculate this protein requirement. And micronutrients are also very important, especially if the patient is on steroid therapy. We have to always consider about the vitamin D and calcium supplementation. Actually, none of these guidelines promote us to supplement calcium and vitamin D blindly. We have to check the vitamin D levels and do a DEXA scan and assess the patient's condition prior supplementing them. Then we have to analyze the diet and see whether the patient is getting enough micronutrients through their diet. If they are unable to meet that through their diet, then we can go for supplementation. Usually calcium 1200 milligrams and vitamin D 1000 international units per day. And other than vitamin D and calcium, vitamins such as A, C, E, which are known as antioxidant vitamins, are very helpful to minimize the oxidative stress-induced muscle damage. So we can ask the patients to eat more and more fruits and vegetables to get adequate amounts of vitamin A, C, and E. And salt, actually the recommended salt intake for COPD patient equals to 2300 milligrams or less sodium per day. That equals to 1 teaspoon of salt. Actually, we should not ask them to reduce salt in their normal cooking, because they already have a poor appetite, and reduction of too much salt, asking them to reduce the salt too much will end up inducing this loss of appetite more. So we can ask them to limit the processed foods in the sense biscuits and those bakery products. Almost all the biscuits have a huge lot of salt in them, especially cream crackers. So it is always better to advise them to not to take biscuits. And if the patient is educated enough, we can ask them to read the food labels and avoid the foods with more than 300 milligram of sodium per serving. And they can use more spices to get the flavor rather than salt. And fluid intake is also very important. Taking an adequate amount of fluid is needed to hydrate the body, and it will help to keep the mucus thin and easy to cough up. So the fluid intake, at least around 6 to 8 glasses full of water would be needed per day. And then a few simple advices for the patient. It is always better to ask them to choose complex carbohydrates over simple sugars. Complex carbohydrates are coming from whole grain cereals. The best is parboiled rice or tambapuhal, and the red rice, and flour like atta flour, not those refined palm piti. And we can use the pulses such as chickpeas, cowpeas, and green gram over simple sugars. We have to actively discourage the intake of sweets, biscuits, especially cream crackers, malted milk, and refined flour bakery products. If the patient needs some weight gain, we can increase the amount of pulses and fruits. But if the patient is too obese and we are planning for weight loss, then it is better to increase the green leaves and pod vegetables. The fiber intake should be in moderation. Too much fiber will induce satiety and reduce the food intake. So fiber intake in moderation, that means around 20 to 30 grams per day, will be helpful in alleviating the constipation and bloating. Usually our normal Sri Lankan diet would give around 20 to 25 grams of fiber per day. Then the quality of the protein is very important. The best quality proteins are coming from milk and eggs, especially the egg white, and some from protein, some soya meat. Uh, if the patient is willing to lose some weight, we can introduce them with some low-fat protein sources such as low-fat dairy or fish and egg white. And if they are taking poultry, it is better to take them without the skin. If the patient is willing to gain some weight, then we can advise them to take some full cream milk, curd, cheese, and yogurt. But we have to be careful on their blood cholesterol levels. It is always better to advise on health and taking healthy fats. Healthy fats in the sense they should take more unsaturated fats, which are coming from nuts, sesame. Nuts means cashew nuts, peanuts, and sesame, soya, olive oil, and fish. All of these food sources are having unsaturated fats, and at the same time, we have to limit the saturated fats. Mainly, saturated fats are coming from the foods of animal origin, such as butter, ghee, and red meat. Coconut oil also has a lot of saturated fat, but we can advise them to take coconut oil as their cooking oil, because taking cooking oil such as palm oil or olive oil can increase the production of trans fat. Because we have to always avoid trans fat as much as possible. Trans fats are full in fat spreads, margarines, and bakery products and biscuits. So we have to actively discourage these patients to not to take those processed food items. And then few words about the respiratory quotient. Actually, respiratory quotient is a measure of the ratio of carbon dioxide produced and oxygen consumed by an organism over cell or biological system per unit time. And this depends on the substrate they use for the respiration or the metabolism. If a cell uses glucose as its metabolite to oxidize one molecule of glucose, they will need 6 molecules of oxygen, and it will produce 6 molecules of carbon dioxide and 6 molecules of water. For the glucose, the respiratory quotient would be 1, because the amount of oxygen consumed is equal to the amount of carbon dioxide produced. Similarly, if the organism use fat as their energy compound, then the fats tend to produce relatively lesser amount of carbon dioxide in relation to the amount of oxygen it is being used. The respiratory quotient for fat is 0.7. For glucose or other carbohydrates, it is nearly 1. For proteins, it is nearly 0.8. For mixed diet, the respiratory quotient would be around 0.9 or 0.8. There are some studies which mention that high fat, low carbohydrate diets would be beneficial for COPD patients. Why? Because this COPD is known as a disease condition associated with hypercapnia or high blood carbon dioxide levels. To reduce this carbon dioxide production, we can use high fat, low carbohydrate diets. But high fat in the sense these fats should come from unsaturated fat sources or healthy fat cells. But this thing is not included in any guideline, because this is still controversial. Some reports have mentioned that there's no much association between these two. So none of these guidelines have mentioned about this high fat, low carbohydrate diets. But as long as if we use healthy fats, we can increase the amount of fat by reducing the amount of carbohydrates. And then the next thing is vitamins. Actually, as I mentioned earlier, vitamin D and vitamins like C, A, and E are very important. Uh, we have to always advise the patients to get an adequate sun exposure, and there are no much food sources that can give much vitamin D. The fish is a good source, small fish like sale, sude, hurullo, and bolu, lino-like fish, the mackerels, and mushrooms also, especially the wild mushrooms, have some amount of vitamin D in them. But most of the mushrooms we consume, those commercially cultivated mushrooms, are cultivated in dark rooms, so they do not have enough or adequate amounts of vitamin D in them. But if we can expose them to sunlight before cooking, at least for 10 minutes, they are able to produce some vitamin D like we do. So we can increase the amount of vitamin D in mushrooms by exposing them around 10 minutes to sunlight before cooking. Vitamin D is a heat stable compound, so it will not get destroyed while cooking. So we can advise those patients to eat more fish and mushrooms in this sense. And then the vitamins like vitamin C, E, and F are rich. Can be taken from vegetables and fruits. And then it is always better to advise them to take frequent small meals, because large meals can end up giving postprandial dyspnea and fatigability. And we can advise them to take soft, easily chewable food. If the food is hard, we can mash them and eat. And if the patient gets tired towards the latter part of the day, we can eat more during the morning time. And if the patient is having early satiety, we can advise them to delay the drinking of water, not to take it just after the meal, but we can delay it up to 1 hour after meal. And it is better to introduce a midnight snack or bedside snack or late night snack to bridge that energy and protein gap. So this is the food pyramid for COPD. Actually, this is a newer concept introduced in 2020. The base of the pyramid contains mineral water, vegetables, and fruits, and then comes the healthy fats and whole grains. The top of the pyramid contains unsuitable sugars and saturated and trans fat foods. Then a few words about the use of nutrition supplements in COPD. Actually, nutrition supplements are sort of a scientifically developed nutritional compounds, which we can they usually come as powders, and we can add some water and prepare a drink. It can deliver quite a lot of energy and proteins to the patient. And actually we can use these nutritional supplements in COPD patients because they can deliver more energy and proteins in a low volume, more palatable and effortless way. There are evidence from systematic reviews to show that the provision of ONS or addition of ONS in diet in COPD can significantly improve the quality of life. And they are even included in some guidelines as well. But the cost is the problem. In Sri Lanka, one of these the scientific nutritional supplement would cost around 4,000 rupees or more. So we being a very as we are in an economical crisis, we have to consider the benefit versus cost in prescribing these oral nutrition supplements. But if the patient is able to bear the cost, then we can use these supplements as a snack to deliver or to bridge the protein and energy gap. So that brings the end of my presentation. So in summary, all these COPD patients may be having malnutrition, and malnutrition can increase the mortality, morbidity, and health costs. So it is always better to identify the malnourished people and treat them accordingly to improve their quality of life and to reduce the health costs. Thank you.
much for keeping the time. We can take a couple of questions. I have a question. Sometimes in the EPD we manage bronchial asthma COPD spectrum. If it's a COPD predominant acute exacerbation, role of magnesium sulfate. That is number one. Number two, when there is an infective exacerbation of COPD, out of the macrolides, what do you prefer? Like, is it erythromycin, acetro, or erythromycin? Can I ask the second question first? Now, clarithromycin and azithromycin is the newest generation before the ketolites came. Azithromycin has a very good tissue level. It will spread. About 80% of the drug will be in the tissues, where clarithromycin is a blood antibiotic. So that is 80% of that is in the blood. So that during severe pneumonia, and when there is a bacterial phase, Clarithrol is a better drug than acetro. Here, in COPD patients, it is they get severe pneumonia. So in that case, Clarithrol will be preferred. But otherwise, for the chronic bronchitis, that kind of infection, azithromycin is the drug of choice. Erythro is the first generation, but it has their side effects as well as the frequent dosing. Azithromycin is it's once a day. Generally, it's divided if the patient is having GI intolerance, but otherwise, it's a good antibiotic, and it has, in addition to that, it has anti-inflammatory activity. So this one year of 3 days per azithromycin that we give for these frequent exacerbators, that has, in addition to the antibiotic effect, the anti-inflammatory activity. Second question, magnesium sulfate is not well studied in COPD, but always I think it is not going to cause any danger if you are going to give one dose. And then most of the time in Sri Lanka, I see echo more than we see lots of allergic sensitization. Now, with 300 eosinophil count, I mean, we know that most of our patients they have 600 or 700 eosinophil count. So, eosinophil count was less than 100 and hardly unless they have a high dose of steroids. So, that kind of thing. So, therefore, I don't think it causes any harm. As a whole, it does a lot of good. Thank you for that clear answer. Thanks, madam, and the two other panelists. They detailed us regarding the COPD. It's a very relevant time because if you see, we know that there are working medical work, burden of the COPD. So this day, 25% of the data people see the COPD. So as you started, I would like to see the COPD as a preventive disease, as a treatable disease. But I think it's a bit of a, we have a long way to go. Because if you start global, see the preventive measures, in spite of the initiative of the seizure and the smoking, the global prevalence of the COPD is increasing. You see in India and the Philippines, right, for now speaking, second most common cause of mortality. So it's an initiative. See, the more we have to educate environmental pollution and simple things, a lot of things we are not neglecting. Sometimes made biomass gas and all this thing has a preventive measure. Not only smoking, we have to go behind the other large enough environmental pollution, even simple size mosquito coils and simple things. All these things we have to consider. Second thing, we have large majority in this patient we are managing in the public, not in the respiratory unit, sometimes maybe in the small peripheral. Highly they are neglected. All the patients they are inhaler oriented with about 80. So improve the their quality and their mortality. Hardly any preventive. Even some of the initiative we have done in the respiratory unit. And we can't do it really. Not much of the respiratory rehabilitation, even the knowing annual vaccination program, even hardly any patient we can provide the home oxygenation. None of these preventive measures are implemented in our country. In the near future, probably we will not see any probably the preventable or we can't define the COPD as the treatable or the preventable disease. So the burden will be going on. Unfortunately, last part in the COPD patient, still we see a lot of COPD patients die in the medical ward. Last week, I'm very interested about your case. A lot of patients they come with chest pain, stroke. So they not, in fact, not give the progression of the COPD. They die because of the MI published stroke named underlying infection. So the fact that we should be educate all, not only the community, not of our junior doctors, especially in the periphery. You know the fact that most of our COPD are qualified for this study. Some of the patients have the peripheral vascular disease. Sometimes they need more than inhalers. They qualify for probably antihypertensive, probably statin, probably some of the patients qualified for antiplatelet. So the COPD at the moment, COPD is a neglected area in our country. Right? So thank you, Madam, Sir, we are this forum. The COPD not only this program, but in the country-wise, island-wide, there should be education programs, healthcare workers, as well as the public, because we are in order to prevent COPD in future as a preventable disease or a curable disease. Thank you very much.
Thank you so much for that excellent comments. Actually, one of the most respected junior consultants in my life. I respect him so much and so very much to me because this so reflected all my thoughts. With my thoughts which I have in all the time when I see COPD patient. Yes, I mean actually, I should not be seeing COPD patient. Ideally speaking, you also should not be seeing COPD. These patients should be seen in the primary health care units. And if they do a good job, I will be seeing only the alpha deficiencies. We should be seeing them. So I think we have a long way to go, and I am really optimistic because the medical students, we are teaching them, we are training them. So we hope and pray that we are not going to diagnose group D's in respiratory failure and put them on MIV, but it has a large, huge gap before they reach this, and then they have to when the modalities are just enormous human suffering with this morbidity. So let's hope that we can do something for these patients. Thank you so much for your comments.
We have one more question. Bupropion usage, is it available in Sri Lanka? The smoking cessation, and what is your experience?
Bupropion is not unavailable. It is available, and it is a good drug for smoking cessation programs. We have it, but we don't. I have not personally used it in any hospital, but it has a place. It has a place, and then we have nicotine patches. So we have to have a comprehensive smoke cessation program, but it's actually a big challenge. When we started, starting we have started it, and we are trying to we are struggling with it, but it has somewhere. It has to be. You have to start in various foci and then come out. Bupropion actually has proven its benefit in smoke cessation programs as well as in non-smoking tobacco, this BT training and so on.